Students, I'll pick up here with our lecture on public health, flattening the curve, and the social determinants of health as applied to COVID-19. Social distancing is essentially intentionally creating more physical distance between people as a way of reducing the spread of infectious disease. It can consist of a number of different actions, and not everyone always has the same definitions of which actions are part of it or how strict their social distancing is. But it includes things like holding electronic classes like this one rather than meeting in person, not attending concerts or other large events, not running unnecessary errands, and limiting engagement in the public sphere to perhaps quick trips at off-peak times to acquire groceries, medicines, and so forth. Keeping at least 6 feet of distance between yourself and any other individuals when you're out in public for exercise or recreation or brief errands, and so forth. So social distancing can be a highly impactful public health strategy. However, it can come at significant personal cost. One thing we've already seen with the COVID-19 pandemic is that we've had a dramatic increase in unemployment with a number of people losing their jobs. And even for individuals who have not necessarily lost their jobs, but are paid on an hourly wage or are workers in the gig economy, then engaging in social distancing leads to lost wages. And in some cases, for people who've lost their jobs and previously had healthcare insurance provided by an employer or subsidized by an employer, I guess I should say, they've lost their healthcare insurance. It also is associated with emotional isolation due to the physical distance between people that can lead to a feeling of being socially and emotionally isolated, because humans are social organisms. And there are a number of increased vulnerabilities that get amplified at times of social distancing and isolation. We'll address some of those at the end of this lecture, but one kind of core note I want to highlight before moving forward is there are some populations that can't socially distance, such as individuals who are incarcerated, people who are housing insecure, and people who have jobs that do require engagement in the public sphere at this point in time, including hospital workers, maintenance staff, as well as healthcare providers, grocery store workers, people with certain governmental roles, and so forth. And so when we talk about social distancing as a public good, which I think is really relevant to address in the context of promoting public health, we also need to remember the people that can't necessarily socially distance, and therefore everyone else's social distancing helps keep them safer as well. Sorry about that sound. So there are 3 different approaches for reducing transmission that I'd like to address. In public health, when we talk about trying to address outbreaks, containment is usually one of the strategies that comes up first. It focuses on isolating the cases and quarantining those that have been exposed in order to make sure that the pathogen isn't able to make it out of the bodies of the people that are already harboring it and into new bodies to infect. It's a way of essentially setting up barricades, in many cases socially as opposed to physically, but barricades around the infected individuals and potentially exposed individuals to stop the spread. We are well past the point of containment being an effective strategy by itself for addressing COVID-19. It was used pretty successfully in South Korea early on in the pandemic with some very intensive testing to identify who those cases were and contact tracing to identify who may have been exposed. But at this point in time, in most countries and definitely within the United States, we're past the point of containment by itself being an effective solution. And that brings us to 2 other really big non-pharmaceutical interventions: mitigation and suppression. Mitigation involves slowing but not stopping the spread. It involves some measures which are still fairly disruptive in terms of their impact to the people infected, but that are not distributed entirely throughout the population in order to reduce overall healthcare demand, reduce likely total morbidity that is attributable to the outbreak, and to protect those that might be most vulnerable, but it is not itself enough to avoid overwhelming the hospital system, which brings us to suppression. So suppression is essentially mitigation on steroids. It is a more intensive implementation of a number of different social distancing measures to aim to reverse the epidemic growth, to bring the R0 down below 0, so that you can better control the epidemic and avoid overwhelming the hospital system. However, the measures that are necessary to implement a suppressive strategy are not easy and do come with their own challenges in a number of ways. All three of these approaches are non-pharmaceutical in nature, meaning that they are achieved via different policies and behaviors rather than by taking a drug or a test. They are essentially a way of treading water until we have an effective vaccine for treating COVID-19, which is still somewhere in the range of 12 to 18 months out, until we have better evidence that either existing treatments, like some anti-malarial prophylaxis, or other drugs that we have now that are being tested for their applicability to treat COVID-19, or new treatments like remdesivir, which we've talked about previously, can be shown to be effective. And so when we're thinking about mitigation and suppression as approaches, keep in mind that they don't work necessarily in a vacuum, that they're a strategy to implement while the biomedical, biotechnological side of things is still working on those pharmaceutical treatments, in the hope that we will come up with both more effective treatments for people who are infected and vaccines to protect people who have not yet contracted the disease. So here is a graph that just simply shows some mitigation strategy scenarios from Great Britain. This is from what is now a very well-known official report from the COVID-19 Task Force of the Imperial College in Great Britain that was released about a week ago, just over a week ago now, and that brought with it some big policy shifts, both in the United States as well as the UK, in how the government is approaching addressing and controlling COVID-19. So what you see in this graph, let me turn my pointer back on, is that this very high peak, demonstrated in black, is what we can expect for the number of critical care beds that are occupied per 100,000 population if we do nothing. And we see that this black peak far exceeds this red line down here that shows the capacity of critical care beds at its fullest extent. And so if we have approximately, this low number of critical care ICU beds that are available, even with the full force of the healthcare system working to provide what they can, and we have this high peak of patients in need of beds, that's a lot of very likely excess mortality that might have been of people's lives that might have been saved had they not overwhelmed the healthcare system. Each of the other curves shows different levels of mitigation strategy. And so this green curve here shows what the peak will be and when the peak will be in time, through a strategy that closes schools and universities but doesn't impose any other measures. This orange one shows what and when the peak will be by following a strategy of closely isolating infected cases. This yellow peak shows the expected peak number by a combination of case isolation and household quarantine. And then this blue one, which is generally thought to be kind of like the prime mitigation strategy, shows what the peak will be by case isolation, home quarantine, and social distancing of all those aged over 70. What you'll notice with that blue peak is that even though it is the lowest mitigation peak, it still exceeds the surge critical care bed capacity by a factor of more than 8. And so it does still result in a significant overwhelming of the healthcare system, a significant excess mortality due to not having available supplemental oxygen, ICU beds, mechanical ventilation, healthcare staff, and so forth to treat all the people that need it, even though that peak is still a far decrease in the number that would go untreated with a strategy of doing nothing. Next, we have the suppression strategy scenarios for Great Britain, also from the same kind of now famous Imperial College report. These are a little bit more complicated to interpret, but I'll do my best. So the suppression strategy scenarios basically show a couple of different measures and what we expect over time by following a more strict regimen of combined mitigation strategies to suppress the span of the disease, involving general social distancing, that social distancing of the entire population and not just those that would be most vulnerable. What we see is that if we do nothing, just as before, we see that really tall peak occurring in kind of early mid-June in Great Britain, according to this model, where the surge bed capacity would be overwhelmed by many times. This blue shaded area that you see is the time frame within which the intensive suppressive measures are taken. And what we see is that for the time in which the intensive suppressive measures are taken, the suppression strategies consisting either of a combination of case isolation, household quarantine, and general social distancing, or of school and university closure, case isolation, and general social distancing, are able to bring that peak healthcare demand down near or below the surge bed capacity. And we have that kind of exploded in scale on the bottom graph here so that you can see a little bit more clearly that the measure that includes school and university closure, case isolation, and general social distancing does remain below surge bed capacity for the entire duration of that roughly 5-month period of time in the model where these measures are implemented, while the combination that includes case isolation, household quarantine, and general social distancing without the closure of schools and universities kind of fluctuates around it, being under it for a time, but then also exceeding it, although exceeding it to a much smaller degree than any of the mitigation measures we saw before. In both cases, we do see that after the end of the measure, we continue to see some impact for a time of that lower demand that still stays below the threshold of available healthcare resources to treat COVID-19, but then a secondary rise that occurs where it essentially shifts it further in time rather than stopping it entirely. And so this has led infectious disease specialists, economic modelers, government officials, and so forth to have a number of discussions about suppressive strategies, mitigation strategies, perhaps some alternating between the two, and some discussion of what economic supports can be offered to people and to businesses in order to counteract the degree of economic and social disruption that long-term suppressive or mitigation strategies can impact. So I'd like for us as a class to think about how we can conceptualize health in a crisis. And I want to bring you back to the WHO definition of health that we addressed from the first day of class, which has been the go-to definition of health in the global health sphere since 1946, that it is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think that this really highlights for us our need to consider the social impacts and social and economic ramifications of both the pandemic itself, our fear of it, our response to it, different measures that are taken to it, and so forth, and to put in place different supports for people so that we can continue to stay in as good of mental and social well-being throughout this, beyond just avoiding contracting the disease as much as possible. This has some relationship to the social determinants of health rainbow that we talked about earlier, which was modeled by Dahlgren and Whitehead, that looks at these factors that we generally tend to talk about the most in the healthcare system in terms of different, individual genetic factors, past experience of certain disease or conditions that may have impact on how you experience a new condition, different individual lifestyle factors, and that look beyond those to the broader inputs that influence our health and that actually have a greater impact on our health and those individual level characteristics, like the social and community networks that we build, like the living and working conditions that we operate within, and like the general socioeconomic cultural environment factors that influence all of those. I'd also like to bring you back to our earlier discussion of the social determinants of health from that Richard Wilkinson and Michael Marmot piece that we read, and thinking about how a few core social determinants of health have a really real role to think about in this crisis. And so Wilkinson and Marmot told us about the social gradient and about how social class has a real impact on people's vulnerability to ill health, that disadvantages concentrate across a lifetime, which allows the negative health impacts that people experience to accumulate over that time, leaving some people perhaps without the physiological or social resources to best contend with a new threat like an infectious disease pandemic. We know that stress also accumulates and diverts energy and resources away from physiological processes that are important to long-term health maintenance. And that this, experience of stress and high levels of stress increases a person's vulnerability to infectious disease, along with also making them more vulnerable to chronic health risks. And we know that social exclusion results from racism, discrimination, stigmatization, hostility, and unemployment. That it itself prevents participation in education, training, and gaining access to services, that it can be socially and psychologically damaging, materially costly, and harmful to health, and that it has a dose of response effect, where people that have historically experienced high levels of social exclusion, even if their situation is such that now they are not experiencing as much social exclusion, do show a still higher effect in terms of the damage to their health than people that have not historically in their own life course been experiencing high levels of social exclusion. But one thing that Wilkinson and Marmot taught us that I want to make sure I leave you with is the observation that social support is also a social determinant of health. This is both an opportunity in this time and a critical challenge. We know that friendship, good social relations, and strong supportive networks improve people's health because it provides emotional and practical resources. And we know that high levels of mutual support protect health, whereas the breakdown of social relations reduces trust and increases risk. This gives a really strong argument for putting in place whatever supports we can to maintain those social networks, even in a time of social distancing, which is really physical distancing, because we have a number of different ways that we can try to stay connected to each other socially. It also points towards a lot of reasons to really invest in building new networks of support, implementing different mutual aid programs, for example, to try to make sure that we have these resources of social support in times when we may already be our most vulnerable, and so that we can protect each other as a society. I want to kind of wrap this up by highlighting a few ways in which disaster amplifies existing vulnerabilities for you to think about and for us to discuss further on this slide. So one quick key question I think that we should be considering in all of this is who gets testing and treatment and who doesn't. I'm sure all of you by now have seen reports on social media about certain wealthy individuals and celebrities receiving testing for COVID-19 while they were asymptomatic, whereas we have a number of healthcare professionals and other people with known exposures and risk factors that are highly symptomatic that have been in some cases pleading for tests and unable to receive them. And I think that that disparity may be even more amplified in time with who gets treatments once we do start to have more effective tested treatments for COVID-19 and who doesn't get those treatments unless there are different measures put into place to ensure that provision of care is more equitable, especially in those cases where the healthcare system starts to become overwhelmed. I have uploaded an article to the Blackboard for you. I'll also share a link for it on the Slack on the fair allocation of scarce resources in a time of COVID-19 using a bioethical framework that I'd like for you to take this opportunity to read and address, acknowledging that it's a really difficult and challenging topic. We know that in crisis scenarios broadly, that domestic partner violence increases, intimate partner violence increases. COVID-19 is perhaps a special case where that's amplified even further because not only are people now existing in a state of heightened stress and vulnerability, but many people are now closed up in homes with their abusers, which can lead to increased rates of violence and all of the negative impacts of that as people are socially distancing in their home. We know that there are additional risks to populations that are already marginalized. And for example, incarcerated persons are not able to acquire adequate soap, hand sanitizer, or other means in which to ensure their own protection and sanitation. They are often compressed into crowded settings where they don't have their own freedom of movement. And we know that Rikers Island, which is a prison in the East River between Queens and the Bronx in New York City, had 8 confirmed cases on Friday, 38 confirmed cases on Saturday, 60 confirmed cases on Monday, and we're going to see this trend replicate itself in prisons across the country if more supports aren't put in place to address this before we see even worse consequences than we do now. And we should also recognize that a diversion of resources to addressing COVID-19 leaves other needs unfilled. We see this directly in the operation of the healthcare system, where as more and more hospital resources are diverted to addressing critical COVID-19 cases, that those people who are still having heart attacks or car accidents or need dialysis or other forms of care don't have the same resources available to them. It also has an impact in terms of funding for different social services and social programs, both privately and publicly, that can leave some additional vulnerabilities moving forward in the future for people that relied upon those sources the most. And so with that, I think I've given you quite a lot to think about. I hope that you are well and remain well. I hope that your families are well, and I will see you back on Thursday for our next class session. Thanks.